Hi guys, welcome to this tutorial by Clint IQ on forming a differential diagnosis using the VINDICATE framework. This is a structured approach that helps you to make sure you're considering a broad range of possible causes for any clinical problem. Differential diagnosis refinement is a critical skill for all clinicians to develop, and it's one which is assessed across all of the main health degrees. Medical, nursing, nurse practitioner, physician assistant will all have some kind of assessment that looks at your ability to formulate a differential diagnosis, whether that's an OSCE or a theoretical assessment. A differential diagnosis is simply a list of all the possible conditions that could explain your patient's presentation and symptoms. And having a framework that guides that will help you to think systematically, avoid tunnel vision, and then plan your investigations more effectively, which is what will guide the best possible treatment for your patient. VINDICATE in particular is helpful because it forces you to consider a full spectrum of disease processes, all the way from the most common and obvious to the rare and dangerous. It essentially pushes you away from diagnosis bias. I find it particularly useful in my practice in the MET or Code Blue scenario, where I'm often tempted to make assumptions based on the handover I receive or to focus my assessment on what I think the diagnosis will be based on the patient. By following a framework like VINDICATE, I'm forced to consider all potential problems, and that often leads to identification of polymorbidity. And then as you get more experienced and familiar with using VINDICATE, it becomes a lot more second nature and less like you're reading a script or a list. These are the components that make up the mnemonic. We'll go through each one with specific examples, and then we'll apply a real case in full to really embed it. And it'll be a case from my recent practice. So vascular causes relate to problems with blood flow, blockages, bleeds, or reduced perfusion. You should always consider vascular causes early because they're often time critical. And an example would be a patient presenting with a decreased level of consciousness, and vascular causes for that might include ischemic or hemorrhagic stroke. Infective causes are extremely common in acute presentations. Think about bacterial, viral, fungal or parasitic causes, depending on the clinical context, and then move quickly into sepsis management if suspected. So both in my clinical practice and in my teachings on ALS2 courses, I follow the sepsis 6, and it's the same thing I teach. Take blood cultures, as well as a full septic screen, check full blood count and lactate, administer IV fluids, monitor urine output, give oxygen if required, depending on oxygen saturations and target, and then commence broad spectrum antibiotics, which can be changed to targeted once you have culture results back. Neoplastic includes both benign and malignant tumours. They can present quite subtly, so keep them in mind in chronic or unexplained scenarios, and think laterally. Tumours can be functional and cause endocrine type symptoms as well. Degenerative conditions are common in older adults, and they tend to cause chronic progressive symptoms. So think about things like Alzheimer's, Huntington's, chronic obstructive pulmonary disease, where there's an ongoing progressive decline. Deficiency includes things like anemia, acute or chronic, and then don't forget your drug side effects. They're a huge contributor to acute care presentations, and one that sometimes we overlook. Iatrogenic means caused by medical treatment, and then intoxication can include things like illicit substances or medication abuse. But when you're thinking about iatrogenic, consider things like your medications, if we've prescribed something inappropriate or given an incorrect dose of something, as well as considering complications from things like procedures or post-operative or hospital-acquired infection. Congenital causes are often overlooked in adults because we think about them as being identified and treated in the newborn or as a baby, but many can remain silent for years before becoming symptomatic. And congenital conditions that are diagnosed at birth, like cystic fibrosis, can still be contributing to symptoms or present complications relating to the condition. Autoimmune or allergic conditions occur when the immune system misbehaves, and they often present with multi-system involvement. This is actually a pretty common one for me because I see a reasonable number of anaphylactic patients. Our hospital does a lot of desensitization challenges to things like bee venom and peanuts, as well as infusions of immunoglobulins, iron, and lots of different chemo agents. So allergic and anaphylactic responses are often at the top of my differentials for these patients. Trauma can be major or minor, and even small injuries can be significant in older adults or anticoagulated patients. Anyone with a head strike who is taking anticoagulation, so for example, an elderly patient with a mechanical valve on warfarin, will need close monitoring and imaging to confirm whether or not there's any sort of intracerebral complication from the fall. Endocrine and metabolic issues can mimic other conditions, and they can cause an array of symptoms, so they should always be in your thinking. Examples might include things like hypokalemia-associated paralysis, hyponatremic seizures, hyperkalemic arrhythmias, diabetic ketoacidosis, and so on. So let's apply VINDICATE to a real case. This is a patient that I saw after he was admitted to the ward and flagged as a patient of concern. He'd initially presented with sudden onset shortness of breath and chest tightness, and he deteriorated rapidly and became profoundly hypotensive and tachycardic with a severe metabolic acidosis. This gentleman had had a blood pressure of 65/40, which obviously is not remotely adequate to perfuse end organs, and he had a lactate of 13.9. He'd started going into acute renal failure because obviously he had some renal hypoperfusion, and he was coagulopathic as well. His past medical history included IgA nephropathy, liver cirrhosis, hepatitis, and heavy alcohol use. So first things first. After a really thorough assessment, you can begin to narrow down your differentials. I performed an A to E assessment because he was deteriorating, and then I began to generate a broad list by considering each part of VINDICATE. And then I narrowed it down by deciding what was most likely and what's too dangerous to miss. It's important to note here that obviously, whilst performing the A to E and before spending some time working through differential diagnosis development, I addressed all immediate life threats. So, addressed his hypotension with fluid resuscitation and administration of metaraminol as a vasopressor, and so on. The initial thorough list, and this is the one that I came up with for him, is a really useful tool to follow when handing over to colleagues or documenting. It demonstrates a really robust assessment of the patient, and in something like an OSCE or an assessment type scenario, it shows the examiner or the marker that you are considering all possibilities and can link symptoms to pathology, and that shows critical thinking and good judgment. In this case, the most likely differentials were severe abdominal sepsis, acute pancreatitis, mesenteric ischemia, or a ruptured AAA. And coming up with these most likely differentials then directs further investigation. So in this case, the patient went for a CT abdo, and that confirmed edematous pancreatitis with quite a large purulent collection and free gas in the abdominal cavity. And obviously free gas is quite a clear indicator of a lot of bacteria and infection. So the patient was commenced on ceftriaxone and metronidazole, administered with aggressive fluid resuscitation, normal saline and albumin. Albumin can be a contentious topic, and that will be a topic of another discussion and another session where we'll talk through the whys and whens of giving albumin, and then taken to interventional radiology to have percutaneous drainage of the collection. Often, the surgeons will try to wait to drain until there's been a few days of antibiotics and there's a bit of a wall up around the infection, but in this case, the patient was too septic to wait for that. So in summary, using VINDICATE ensures that your differential is safe, structured, and comprehensive. It helps to guide your investigations and consequently your interventions. And also, as a bonus, it gains real marks in clinical and theoretical assessment. Thanks for watching. If you found this helpful, please feel free to like and subscribe for more content on clinical reasoning and OSCE preparation.